I'm pleased to moderate this session called the Conversations with Industry Symposium at the McLean Hospital Institute for Technology and Psychiatry Summit. And if you're following us on social media, feel free to tweet, post, and share with the hashtag TIPS 2022. So now we'll learn more about our panelists. First, we're going to each introduce ourselves. And then after we introduce ourselves, each industry representative will have 10 to 12 minutes to present their organization's research. Now, following these 5 presentations, the panel will then have a chance to answer questions from the audience, as well as discuss any sort of higher level questions related to the future of mental health and technology, the interaction between academia and industry, regulations, and more. So we all look forward to it being a really thoughtful discussion. So let's go in this order. We've got Yuri Maricich from Pear Therapeutics, Triton Ong from Doxime, Varun Choudhary at Talkspace, Naz Alavi at Health, Zucker at Twill Health. Yuri, could you introduce yourself?
Greetings, and thanks, Steve, and the group for having me. So my name is Yuri Maricich. I'm an internal medicine physician, and both have been involved in clinical practice as well as done traditional drug development as well as digital therapeutics. So I'm glad to be here.
Wonderful. Thank you, Yuri. Triton.
Yeah, thanks, Stephen. Happy to be here. My name's Triton Ong. I am a research associate at Doxime, and right now I focus predominantly on telemedicine and innovative solutions in that realm. But previously, in a previous life, I was a clinical behavior analyst, so happy to be here.
Thanks for being with us, Triton. Varun, could you introduce yourself?
Thank you, Stephen. Thank you, and thank you for having me. Varun Choudhary. I'm a board-certified forensic psychiatrist and the chief medical officer for Talkspace. Prior to joining Talkspace, I was in managed care for 7 years. And previous to that, I was in practice for about a decade, where I started with telepsychiatry back in 2006.
Wonderful. Thank you, Varun. Naz, we'd love to learn about you.
Thank you, Stephen. I'm glad to be here today. I am a psychiatrist at Queen's University in Kingston in Canada, and I am a chief medical officer at Health. And I have been working in digital mental health since 2007, and that has been my field of research. For many years, I was working at CAMH, and then I moved to Queen's, and I'm happy to be here today.
Have a lot to unpack today. So without further ado, Yuri, let's get started with your presentation.
Great. So thank you again. And what I'm going to touch on, since we only have 10 minutes, is prescription digital therapeutics, which is a class of digital treatments that are now being used more and more for patients. This is a brief disclosure statement just to say that this presentation does not include all necessary information for the safe and effective use of Reset and Reset-O. There is nothing in this presentation intended to imply or suggest claims regarding our paired PDTs beyond our FDA cleared labeling, and that this presentation is for educational purposes, and I am an employee of Pear Therapeutics. So as many of us know, and I think the reason many of us here is that we are seeing enormous challenges across mental behavioral health, as well as substance use. We're facing an epidemic, and despite telemedicine and continued expansion of access to care through telemedicine, we're still seeing a lot of challenges. We know, on the other hand, that technology is pervasive. Americans spend a large portion of their time on mobile devices. We're seeing greater adoption of digital, and we have a mental health clinician shortage. So PDTs are a new class of treatment to help address serious disease across disease areas, but particularly in mental behavioral health and substance use. Many of us are familiar, may use in our own personal experience, different types of health and wellness or population-based tools. And so they are similar to that in that they can be accessed via traditional mobile devices. And you see that listed here. What separates them is that they also have similarities with traditional pharmacotherapy that we may use. So one is they deliver evidence-based mechanisms of action. Two is that they require randomized control trials. Three is that that data gets collected and then submitted to FDA as part of review. And then if the FDA agrees and provides approval, authorization, or clearance, they then have a label to treat disease, and that supports also product-specific codes that facilitate reimbursement through third-party, both public and private reimbursement. But what's unique from pharmaceutical products, and that you can see over to the far right, is that there is information that can go back to the clinician, can go back to the provider care organization around population health management. And one of the exciting things we're starting to see more and more is we're seeing patients being prescribed these in the real world, as we see tens of thousands of now patients who are being prescribed and treated. We're also seeing public insurance. For example, Massachusetts Medicaid now covers PDTs. Oklahoma Medicaid covers PDTs, and we're seeing commercial and PBMs starting to cover. Just a little background on the review process and this plays into the evidence is that these types of software-based interventions are run through randomized clinical trials, evaluating both safety and effectiveness. And importantly, this is type of data that helps us as clinicians to understand, is this appropriate for the patient in front of me? How does this fit into clinical guidelines? How do I think about this relative to other types of treatment I might use? Then the FDA can review it either as part of a de novo or 510K if there is an existing predicate. But importantly is if you look at existing PDTs and their de novos out there, the FDA is required that every single one of them, even if it's a 510K, is required to have their own clinical data from their own clinical trials to support reasonable assurance of safety and effectiveness. And then after FDA review, if they do make a decision to approve, authorize, or clear, then you can see in the far right, post-market surveillance is required. So just like any pharmacotherapy out there, the manufacturer is required to comply with FDA standards. They are audited with regular frequency, and they evaluate for safety as well as complaints. But this also provides a feedback mechanism to make them better and better. One of the aspects around PDTs is generating evidence across different types of studies. So these are three therapeutics that are on the market. You can see the first is for patients with substance use disorder. That's called Reset. That was our first to receive FDA market authorization back in 2017. Reset-O is for opioid use disorder. Importantly, it is intended to be used alongside the medication buprenorphine naloxone. And then third is Somryst, which is for chronic insomnia. And each of these actually represent different example use cases in the clinical care paradigm. You can see a column under RCTs and a list of some of those randomized clinical trials that have been published in peer-reviewed literature, supporting and evaluating those interventions. But one of the exciting things about digital is that we are able to also collect real-world data, either in observational or in comparison type real-world evaluations, to not just look at internal validity and causality in the RCTs, but to look at external validity and generalizability in that real-world data. And you can see a list of some of those numbers of patients that have been published. And then lastly is we can look at claims data to help evaluate questions around value and impact on the overall health ecosystem. And so the far right, you can see durability data, looking at claims and analyzing things like reduction in inpatient stays, hospitalization. We can also look at pharmacy claims to see if patients are filling their claims. And this helps support payer organizations and managed care organizations, as well as other policy decision makers. As we think across data sets, though, it's important for us to make sure that we are collecting evidence that helps us to understand how this can be used in different patient populations. And so one of the areas of focus we have is looking at groups of patients that are representative of the patients that we need to decide whether or not this is the right type of intervention for them. And so you can see there's a little check mark where we have data so far evaluating these. So you can see, for example, in women, in older adults, in people of color or other ethnicities. It's really important for us to look at low socioeconomic status. For example, 70 to 80% of our patients treated with Reset-O in the real world are Medicaid. Inclusion of people with 12 years or fewer education, rural, and also people in the criminal justice system. And there's more and more work, I think, here that we should all be focused on to continue to do to understand, is this right for my patient and how can this be used in different patient populations? Just to wrap up very briefly, so this is an example. By now you might be wondering, well, what are these things, Yuri, and how do they work? So as an example, Reset and Reset-O have two components. The first is a patient-facing component. So Reset and Reset-O, very similar, but they have three mechanisms of action. The first is an addiction-specific form of cognitive behavioral therapy that helps patients who are actively using substances to reduce from a harm reduction perspective, and then for some who want to discontinue to move into recovery. Fluency training, which helps assess proficiency and reinforce concept mastery. Contingency management, which is a evidence-based behavioral reinforcement mechanism that is highly effective in substance use and opioid use, but unfortunately has been very difficult to access and also to fund. And then third is we can also include different types of patient-reported outcomes. So patients can input cravings, triggers, their substance use, and that information can go back to the clinical care team to inform overall management and clinical decision-making. And the way that's done, as you can see to the right, the clinician-facing dashboard. And we now see health systems and other provider organizations actually integrating this into order sets, into electronic health records to help facilitate standard clinical workflow. I think the other thing that I'm most excited, and this is one of the great things I think the TIPS conferences are helping people get together and talk about, are how digital treatments like PDT is able to help us to address a number of things. Things like the clinician shortage, which I mentioned earlier, but also to help us figure out how can we comply with or adhere to clinical guidelines. How can we expand treatment options for patients who don't have good treatment options or disease areas where we don't have good pharmacotherapy? There's an ability for provider organizations to use much of the data to help support important quality metrics like STAR, HEDIS. There's the ability to use data to support value-based agreements. And lastly, I think to really facilitate novel care models. And as Stephen mentioned at the beginning, things like asynchronous care. How do we think about combination or the right amount of synchronous versus asynchronous care? Lastly, and this is just kind of a practical slide here, is as we develop these new classes of treatments, how do we integrate this into workflow that's convenient for patients as well as for clinicians? We already are asking all of ourselves to do more with less and less time. And so this is just a very simple patient journey, which shows how patients get access, for example, to the therapeutics that we have developed. So patients meet with their clinician, whether in person or virtually. The clinician can write a script either in a portal, or we're seeing more and more via ERX, via their EHR. For example, we're in the Epic App Orchard. The patient will then receive an initial text asking for consent to communicate. And then if they opt in, then they get an access code with a link to the Google Play or the Apple Access, Apple App Store. They can download their software, they confirm their identity, and they can actually be on treatment still in their in-person or even when they leave a virtual appointment. And then the clinician can view their data, particularly within their next appointment. So really appreciate the opportunity to speak to you all today, and looking forward to hearing more from others in the follow-up discussion. Thank you.
Thank you so much, Yuri. It was wonderful getting to know about prescription digital therapeutics. Up next is Triton Ong from DoxyMe, who will speak with us about his company. Triton, take it away.
All right. Thanks, Yuri. Thanks, Stephen. My name's Triton Ong. I'm a research associate from Doximy, as we already said, but really excited to be here, really excited to be part of this panel discussion. And I'd like to talk really quickly about how we do research-based telemedicine solutions. So as a company, we were founded for the purposes of clinical research. We were actually founded by Brandon Welch, who at the time was a graduate student, and he was doing research in genomic therapy for pregnant women in rural Utah. And as you can imagine, not a whole lot of better populations who would benefit from telemedicine, but back in 2014, at the time, there weren't many great options for doing that kind of research. They were either very complicated and they required a lot of special setups or downloading apps and having patients to remember passwords and logins and all that kind of stuff, or they were expensive and designed for large clinic groups or boutique hospitals and things like that. Or if they were easy and they were cheap to use, they tended to be designed for things that had nothing to do with healthcare. So things like classroom meetings or board meetings and things like that, where people drop in and out anonymously and just not really made for the healthcare experience. So in 2014, they really figured things out at Doximy, where they've just made things very simple, easy, secure, and platform agnostic was really important. So right now, that's really the moxie behind Doximy is all of the options, all of the solutions that we offer are platform agnostic. All the patient has to do is click a link. It works on any browser, any device, any operating system, and they can meet with their provider. No management of anything on the patient's end. So with Simple being figured out, you can see here, our growth was pretty steady, linear, but steady, and we were doubling our user base just about every year. And then, of course, when COVID hit, everyone jumped on board. Everyone's doing telemedicine now. I think it's fair to say that telemedicine has become a normal thing. So when we mean everybody, this is really what we talk about. This is all the Doximy users that are clustered across the global map here. And you can see it's become a very global phenomenon of telemedicine. And I am, of course, preaching to the choir here, but it's fun to visualize what's going on. So if we zoom out a little bit, or zoom in rather, and look at specifically who's using Doximy, as you can see in that very top bar on this graph, the lion's share of our users are behavioral health and social services providers. So that's good people such as yourselves here at TIPS, psychiatrists, mental health providers, social workers, things like that. And really, that's not a surprise. If we look at the populations who embraced telemedicine before COVID, when it was difficult, when it wasn't covered by insurance, when it wasn't really necessarily HIPAA compliant, it was always mental health providers leading that charge. So it's not a surprise to see that now that it's become standard, it's still mostly mental health providers. I want to talk a little bit about the products we offer, not as like a demo or anything, but just to contextualize the research that we do here at Doximy. So our core product is telemedicine. That's simple, free, and secure. So that's basically the interface that we're using right now. So it's video, it's voice, it's chat, it's all the features that you use to connect a patient and a provider. We don't match patients with providers or anything like that. That's not the kind of services we provide. We are really just whatever the provider needs to meet with their patients, that is the need that we fill. So having grown from there, we do also now offer Adherely, which is a simple, secure, HIPAA compliant solution for therapists to assess their clients, to introduce evidence-based practices during sessions and practice those with their clients, and then also to assign those using automated text reminders as homework for their clients, and then track progress over the duration of treatment. And then the last big product I want to talk about is DocBot. This is essentially our chatbot for automated data collection. We have found that there was a need to basically collect data from clients and get it to providers, but forms really weren't working. It's not very fun trying to explain how to fill out a PDF and things like that. So that's what the role that DocBot fills. It's automated data collection. So how do we come to having all these great products that everyone likes and uses? Well, in 2020, when things really got bad for COVID and people started flocking to telemedicine, we really knew that we needed to take this seriously and think globally in terms of how we approach things. So we founded an internal research team, Doximy Research, exclusively staffed by academic researchers. So the goal of Doximy Research is separate from, say, our team that does user research, and it's separate from our business insights who looks at like use patterns in telemetry and things like that. our goal is really broadly to understand and enhance telemedicine practice. And toward that end, since our founding in 2020, we have published 17 peer-reviewed publications, and they broadly fit into these three categories here. Obviously, the first and biggest one is going to be understanding telemedicine use and perceptions. So with the pandemic and the uptake in telemedicine, we have been essentially surveilling how telemedicine is being used, how those use patterns change over time, and how patients and providers think about that use of telemedicine. Perspectives change over time, so it's really important that we are publishing on this pretty frequently, and it's really interesting to just see what providers and patients think of their telemedicine experiences. And based on those experiences and what they tell us, obviously we identify pain points and we develop products to meet those needs. So this is where we do research and development on new solutions such as DocBot, where we essentially compare it to other standard procedures, other standard options for collecting data collection and whatever the solution may be. The third group of research that we do is really exploring the future of telemedicine. So now that things are more or less settling down, now that things are more or less normal for telemedicine, we are comfortable, but we are interested in what things are going to look like in 5, 10, 15 years. So we have started to branch into emerging technologies, metaverse technologies, artificial intelligence, natural language processing, all these things that aren't quite ready for patient care yet, aren't quite ready for telemedicine today, but in 5 or 10 years, they might be. So we're looking to see how we can prepare to be delivering valuable solutions for providers in the future. And how we've gone about this whole academic research process, we've been built on academic research. We do academic research in the development of our products and our services, but how we've really been pursuing this is through the pursuit of federal research grants. So in the past, we've had grants through the National Institute of Cancer and the Department of Defense, but right now our 3 active grants are mostly with the National Institutes of Health. So the first one we have is a phase 2 STTR with Doxy.me, where we are focusing on the process of how people do informed consent over telemedicine. If you think of this before telemedicine, it was a lot of manual processes, handing papers back and forth, getting signatures, saving it in a desk. That doesn't really translate to what we have now with telemedicine. So our task at hand is to develop solutions for that and scale it for a user base as large as Doxy.me. The second grant we have is with the National Institute of Mental Health. This is a phase 1 SCTR where we are implementing the Adherely solutions, which again, as a reminder, is for therapists to assign and manage the practice of evidence-based exercises with their clients during sessions and then also between sessions and tracking that progress over time. So right now we are implementing Adherely and we are conducting a small-scale trial in preparation for a large-scale trial down the road. The third grant that we have right now is for Doxy.me VR. So this is also with the National Institute of Mental Health. This is a phase 1 SBIR. Our goal with this is essentially to conduct discoveries, interview people on what they think about the current state of telemedicine, and based on those interviews, develop a prototype and demonstrate the initial feasibility of virtual reality-based telemedicine for mental health care. The last thing I want to talk about how Doxy.me does research is basically how we recruit people. So obviously, as employees of Doxy.me, we have plenty of access to our own users, but Doxy.me is not all of telemedicine. Not all telemedicine providers use Doxy.me. So we're well aware of this, and looking forward into the future, we are building networks of providers and patients who are not Doxy.me users, just general population across the board, and trying to populate this research panel to essentially have a list of people who are interested in contributing to the telemedicine research that we do. The goal is always to improve telemedicine, not necessarily, wave the flag of Doxy.me, but our interests are broader in that regard. So we're looking to fill this group, and we've had really good success and really interested people joining so far. And that is one of our larger focuses at this point. So to summarize how Doxy.me does research, we make database decisions. Our company was founded by clinical researchers, and we've always kept this in mind, and it's an intimate part of how we do things. We've built a team of academic researchers, a department essentially within the company, and our only task is to focus on provider and patient opportunities. So the academic research oriented towards that also then informs how we innovate in collaboration with public entities and grants. So that's how we do research. That's my talk. Thank you very much.
Triton, thank you so much for sharing about DoxyMe and all the research initiatives that your team has. Now we'll go to Varun Choudhary with Talkspace.
Thank you, Stephen. And thank you, TIPS, for having me. And I'm very excited to be here. Again, I mentioned my name is Varun Choudhary. I'm the Chief Medical Officer for Talkspace. And in my role, I have oversight over our clinical practice, which includes our full-time national provider network and network of thousands of independently contracted therapists and providers. Next slide. Just to give you a brief overview of what we'll be covering today pretty quickly, since we only have 10 minutes, I'll give you a Talkspace overview and then get into some of the forthcoming research that we are doing. Next. Most of you are probably familiar with Talkspace. We are the leading virtual behavioral health company that connects people to a network of licensed therapists and board-certified psychiatrists from anywhere. Next slide. Talkspace has thousands of licensed providers across all 50 states, and it's made up of full-time Talkspace therapists, which are called our national practice providers, and independent contractors who work more flexibly, sometimes supplementing their own practices. Next slide. So just wanted to give you a little bit of background, and I'm sure everyone already knows this, but we've got a growing mental health crisis that has been strained by the pandemic. And previous to that was already a very siloed and fractured infrastructure, but has gotten much worse. Mental health visits prior to the pandemic were noted to be out of network 5 times more than a primary care physician visit. So as a result, most people started getting behavioral health care from their family physicians and primary care physicians, or went to the ER. As a result, 4 out of 5 prescriptions are actually written by family doctors or primary care physicians who aren't trained to treat mental health conditions and illnesses. And the wait time for people to see psychiatrists in person, again, this is prior to the pandemic, the wait time was more than 5 weeks to see a psychiatrist. And also 50% of providers didn't accept insurance. Now, this is data that was pre-pandemic, and you can just imagine how much worse things are now. Next slide. So that was the backdrop against which we launched our psychiatry offering in 2018. And we were set up to treat members virtually before the COVID pandemic accelerated the rise in telehealth services. So Talkspace is combating these issues by connecting patients to available prescribers in 5.6 days with a national network. We've got specialized psychiatric providers that consist of MDs, DOs, NPs, and PAs. And all of our MDs and DOs are psychiatrists, and all of our nurse practitioners in the network must have psychiatric mental health certification, PMHNP, for those who love initials, or at least 2 years of specialized psychiatry experience in addition to being board certified. Talkspace credentials are all the providers in order to ensure that we are meeting the NCQA credentialing and recredentialing standards that are used by payers and the industry. And we're proud to say we've got a very diverse network. We've got 57% of our prescribers that self-identify as BIPOC. Also, we've got a very strong emphasis on clinical quality and strong policies and measures in place to make sure that we're meeting the standard of care. We do not, nor have we ever prescribed controlled substances like Adderall and benzos, et cetera. Next slide. We're committed to research in order to validate the efficacy of this treatment. We have numerous studies published in peer-reviewed journals in partnership with leading academic institutions. In the past 10 years, we've invested heavily in research, spearheaded by Dr. Derek Hull, who's our head of research. And we've got partners at Harvard, MIT, Penn, just to name a few. And we're very proud to have research grants from the NIMH and working closely with an advocacy group called Mental Health America. So together with our research partners, we have published about 20 different studies. Next slide. We do have new research and information to share. I'm excited to share one of those studies in particular that looks at an incredibly important segment, our frontline healthcare workers. The study is currently in review and will be published hopefully later this year. But I wanted to share it for several reasons. One, for those of us in healthcare and behavioral health, we know all too well the impact of the pandemic on our peers and how burnout persists. It shows a very real use case for asynchronous versus live therapy. This is also something very near and dear to my heart. Prior to the beginning the pandemic, I worked with the Medical Society of Virginia to initiate the Safe Haven program, which was founded during the pandemic to provide healthcare workers mental health supports and prevent burnout. And these efforts actually were the foundation for the Dr. Lorna Breen Healthcare Provider Act, which President Biden signed into law in March of this year. Next slide. So what do we mean by asynchronous therapy, specifically from a Talkspace perspective? Talkspace is a telemental health platform that enables licensed psychotherapists to deliver care through asynchronous two-way messaging methods. And this includes text messaging, audio messaging, and video messaging. Talkspace pioneered this technology over 10 years ago. You can text, audio, or video message with licensed therapists around the clock. And it's like being in a conversation with someone throughout the week, a trusted friend, and the room is always open to you. Next slide. So looking at our study, Dr. Hull and Talkspace, in collaboration with NYU and Cornell Tech, undertook a study to understand how asynchronous therapy might be beneficial to frontline healthcare workers. We followed a cohort of 1,873 healthcare workers from multiple US states who engaged in messaging during the COVID-19 pandemic starting in March 2020. The users included physicians, nurses at several levels, residents in training, and a small number of non-medical sanitation workers. Next slide. So for this study, we were able to leverage machine learning capabilities, what's called NLP, or natural language processing. And this is the ability of a computer program to understand human language as it's spoken and written. The data suggested clinically significant improvement in healthcare workers with clinically diagnosed primary anxiety and depression from baseline to 12 weeks. 56% had clinically significant changes, positive changes. The improvements shown by healthcare workers translated into a large effect size that puts it on par or even higher with effect sizes reported for traditional therapy. This is a very strong response on the upper end of outcomes we tend to see, suggesting an especially good fit for this population. Next slide. Some of our other main takeaways are here. This sample was actually more severe at baseline than our historic user sample. And it's clear from the analyses that roughly half of the healthcare workers sought care for problems that predated COVID. So they saw this as an opportunity to finally get some treatment. For the other half, concerns about bringing COVID home or experiencing patient deaths were a significant source of stress, leading to depression and anxiety, as well as panic attacks. In analyzing the data, we got the sense that many of these messages were sent by healthcare workers while they were at work. And we scanned a lot of present tense verbs, suggesting that the messaging with the therapist might have been a lifeline they otherwise would not have had in a stressful environment. Next slide. So that's one segment and use case for the asynchronous platform. Other things we're considering for the future, looking at increasing access. So through our continued research with Mental Health America, we hope to help glean industry insights for reaching and serving a broader and more diverse audience. We're looking at growing our provider network in a way that's truly representational and growing our full-time national practice, especially in states of high need. Looking at specialization, we saw one segment with healthcare workers, but we're looking also at how our platform can cater to specific conditions and other subpopulations. For example, exploring addiction supports and services. And another area of really looking at a comprehensive integrated care model. How can we go just beyond our small area and really impact primary care? And with that, I would mention that we're very interested in the collaborative care model that has come out of University of Washington 20 years ago. And the APA has endorsed this as well. It's one of those areas where behavioral health can have a bigger footprint and serve more people, because as we know, most people are still going to the primary care physicians for behavioral health treatment. Next slide. That ends my presentation. Thank you very much for allowing me to share more about Talkspace and be part of the discussion. Please reach out to me directly if you have any questions I can answer, and I'd be happy to keep the conversation going. Thank you.
Thank you so much, Varun. That was wonderful. Naz, I wanted to turn to you for Opt Health. Take it away.
Thank you, Stephen. So as I also introduced myself already, I'm Naz Alavi. I'm a psychiatrist. I'm Chief Medical Officer at Opt Health, and I also lead a research lab on digital mental health at Queen's University in Kingston in Canada. Been working in the field for over 15 years. So today, what I'm going to what we are doing at Opt Health is on developing scalable and engaging solutions to address mental health challenges. About 50 million people in the United States are in need of mental health help, and with like about 25,000 psychiatrists, about 2,000 patients just have access to one psychiatrist. So as also people today mentioned, the average wait time for like getting initial evaluation was about 1 to 2 months. However, that has increased significantly. We were looking and it is now like up to like 8 to 9 months. So like the question is how like we're going to address that and what can be done. So a hybrid model is something that could be looked into. And one of the things is that like self-guided model is one thing. It is like scalable, but has low retention, and it is like has poor outcomes. If like we look at full supervised options of, for example, psychotherapy, it has good outcome, but it has a limited scalability, and it has high costs. So the question is like where in the spectrum each patient should be to like what level of care they would need, and that is like the question we would ask ourselves. And so what like we do in Opt Health, like what we have designed is that we have different modalities of like psychotherapy. We have cognitive behavioral therapy for different diagnoses, and like I put one here for depression. They are 12 weeks, and each week the patient will receive a session, and they will go through it, and they will receive a feedback from the therapist. And they are all therapist guided, but we have done over 10 trials, and at this time we have 12 trials active and looking at different research on different modalities that we have designed. So like looking at the impact and outcome of the online psychotherapy, we have seen that the reduction in symptoms is about like 30%. Like comparing to like in person, also we have seen two times improvement in treatment completion. And we have like trials that we have looked at in-person psychotherapy compared to online psychotherapy, and we have done randomized controlled trial, and we have published the result. We have seen increase in capacity by 3 to 4 times. The reason for that is the modules that we have designed, they are pre-designed modules. So the patient doesn't come in person. They go through the modules, and the therapist doesn't spend an hour with the patient. They go through the session, the response of the patient, and it takes the therapist about 15 minutes, maximum 20 minutes to reply back to the patient. So instead of having one patient for 1 hour, they can have 3 to 4 patients. So the capacity increases by 3 to 4 times, and there has been a saving in the cost by 10 times. So what I wanted to specifically discuss today is like the model that we are using in Opt Health is our NLP and our AI model. So as I discussed, is the important thing is what level of care a patient needs. It's like only online psychotherapy with a therapist writing back and forth to the patient like once a week is enough, or they might need more support. So some of the patients might need that the therapist call them like weekly and like for 10 minutes or 15 minutes and to provide more support. And some patients might need to see a psychiatrist to adjust their medication. So with that in mind, what we have done, we use deep learning neural net language algorithms that are available, and we trained our own engine on top of it. So we made it appropriate for clinical evaluation. So in this model that we have designed, we give the statement to our machine, and then we will have an output. In the output that we have, it will tell us that the statement that the patient has, for example, written, how much of it is like anxiety, how much is it depression, and also it gives us like the percent of like negative thoughts, positive thoughts, the behavior, the situation. And then we compare that with the like a human agent who is like a clinician who is trained, and we compare our machine, we have compared it with this person, and there is 90% accuracy. So what you see here is that we have looked at 250 patients, their result and their homework from 3 clinical trials. And we have looked at all symptoms of anxiety, depression, and all the emotions, reactions, thoughts, situations from all 12 sessions that they have had. And we have looked at all the changes during this time, and we have done labeling. So what this has shown us, it is like their journey and how this has changed. What we think that this should be something that should be done for everybody, and it should be standard of care for somebody who goes through therapy. And with, like what you see that it says symptomatic, like in the last chart, it is combination of all above charts together, and that shows the changes that you see like in the all the combination of like from session 1 to session 12. So similar to like a growth chart that a child has, this is the changes that you will see in the therapy in the 12 sessions. So using the NLP and AI, we can predict patients dropout with about 66-70% accuracy 4 weeks in advance of patients dropping out. And this is like without like the PHQ-9 score. So what is interesting, because some people ask, what about like PHQ-9 and other questionnaires? So while PHQ-9 score is not a good predictor of treatment completion, it is a good predictor of final mental health status state. And it is the best predictor of the patient's final PHQ-9 score. We think that there is a drop in PHQ-9 score by like 4 or 5 scores, but we can't say by PHQ-9 if they will complete the 12 sessions of psychotherapy or the CBT or not. So we did a trial, a randomized control trial. We did a step care study. So in that study, patients started the online CBT, but during the care, based on their need and decision of the clinician, the level of care changed. So if the patient needed more care, like they would receive weekly, like 15 to 20 minutes of like phone call or video calls from their therapist, or they would like see a psychiatrist every couple of weeks to adjust their medication. In that step care study, we saw 20% increase in number of completed sessions and 30% increase in treatment completion and 35% improvement in clinical symptoms. So with that result and the previous one that I showed, we made our algorithm. So if the completion chance that we get is more than 50% and PHQ-9 is under 19, we think that there is 60% there, like the people who completed ECBT only program, it was 60%, and 20% had final PHQ-9 score more than 14. So we think that these people, if they only receive the online CBT with like a therapist, like weekly receiving feedback, that should be enough for them. They don't need more like support. And this is about 35% of like the patients. And if the completion chance is under 50%, and the completion chance is like what we have calculated based on the what I showed in based on the result of that 250 patients, the charts that I showed, and or the PHQ-9 is more than 19, then 41% completed the ECBT only program, 30% had final PHQ-9 more than 14. So in this group, which is 50%, we think there should be weekly engagement through like phone or video based on the patient's preference as well. And if there is under 50% completion chance and PHQ-9 more than 19, then we think that there should be supervised CBT weekly engagement and probably seeing a psychiatrist to probably change the medication, and this is 15%. So what now we have and what our algorithm does, in the first session, like we have a triage module, and the patients go like through that. And there is like what our opt-out is, what we like offer, and the modules, and they share their story. So here you see they like tell me about yourself, and when they write it and they submit it, then the algorithm tells us what their symptoms are. So it says how much it is anxiety, depression, and it also says which module is the best module for the, you can see it here. So it says like what symptoms they have more, what module is the best for them, and what care level is the best. Is it only online CBT? Is it that they need like more support from the therapist, or they need to see a psychiatrist as well? So from before they start it, the algorithm suggests to us what they need. At this time, we have 15 to 16 different modules on opt-health from different cognitive behavioral therapies for depression, different anxiety, OCD, PTSD, alcohol use disorder, dialectical behavioral therapy. And also our algorithm can say what level of care they need. We have a research lab at Queen's University with 26 members there. We have 12 active trials. We have published now more than actually 15 peer-reviewed articles. We have written the first handbook on how to deliver online psychotherapy. And I would like to thank Dr. Omrani, who is also a co-founder and CEO of opt-health, and Dr. Shirazi, who is our chief data scientist, and my research lab, who have a big role all this work. Thank you.
Thank you so much, Naz. We learned an incredible amount, and we have some questions from the audience. And we'd like to get started with the first question. This is for everyone. What we can do is we could go in this order. We'll go with Yuri, Triton, Varun, Naz, and Murray. The first question says, as a question, how do we balance keeping your products up to date as new research and standards become available, while also acknowledging that the product is subsequently changing during those updates? from when it was initially approved or contracted for use. Yuri, would you like to take the first response?
Sure. I love this question because it's a really important one. And I would maybe describe kind of two categories. I think one is that it is important as we make changes that we understand, are the changes positive, are they neutral, or are they negative? That can be to engagement, that can be to expanding the patient population, and that can be to outcomes, be it safety, effectiveness, et cetera. And so I think it's really incumbent on anyone, regardless of whether they work for a developer organization, an academic, et cetera, who's building solutions for research or otherwise, to collect data to measure that impact. And thankfully, one of the values with digital is while we can change and modify, we can learn much more rapidly. And so trying to identify what are those measures that we can use. I think the other thing I'll just mention very briefly here, Steve, is thankfully you don't have to figure this out alone. FDA has actually guidance around changes to software, and they actually have a process, which is a design control change process. And so that provides some parameters to help organizations guide them through that process and understand when do you even need to collect data, when do you not, right? You don't need to run a new study when you have a new operating system drop from Apple or Android and you're just changing to support that. You might want to do verification validation testing to make sure the software performs. So that's some of my suggestions, and I think there's some good tools out there to help organizations through those.
Excellent, thank you. Triton, would you like to share any responses?
Yeah, I think a lot of us are going to follow the same principles that Yuri just laid out. But in a nutshell, the way that we go about changing things is slowly. We have this mantra we have internally where we start with no. Anytime someone's proposing to change something, well, you're messing with an established product, you're messing with people's workflows. Start with no, and then from there, if it proves to be a good idea, if it proves to be something that actually does make a difference, we have many touch points where we are collecting data on the provider side of things, and we are interviewing people constantly to just see how they're using it, what their opinions are, and how they would react to hypothetical changes. So very slowly, very methodically, and piece by piece. The idea is if we are going to change something big, introduce it slowly to the point where they won't notice that we changed it at all.
Got it. Thank you. Varun, would you like to share about how
Yes.
Talkspace?
It's sure. So the advantage we have is that our platform and product is all built and developed in-house. So we've got the advantage of having the engineering team and the product team there whenever we need to have any kind of change. And so we actually meet in a multidisciplinary team on a monthly basis where we've got the clinical team, product team, engineering, everyone at the table really evaluating the evolution of the product. And the clinical team collects feedback from all of our providers. And so we have a constantly improving and evolving product. So that's one thing that I think is a huge advantage for us.
Naz, how about you? What about OptHealth?
Yeah, thank you, Stephen. Our platform is also very unique because all the modules that we have, which is about 15, 16, they are all clinically validated, and the trials that we have done for some of the modules is even more than one. So they are all also published in peer-reviewed journals. For some of them, we even did a pilot first, and then we did a randomized controlled trial. So if we want to make a change, we first run a new trial before making any changes. We won't make any changes before running a trial.
I think we covered quite a bit about how updates can be rolled out and also researched too. This next question from the audience is also for all of our panelists, so we'll go in the same order. This question asks, can you share how you quantify the impact of your products and services, and whether or how this process informs your offerings, whether they're published or via peer review or done internally? Yuri, would you like to go first?
Certainly. So when I think of evidence, I guess I think of a couple things. One is evidence should really help us answer questions. So I think it's important for us to think about how is the data fit for purpose, and what questions are we asking for the data to help us answer, and then what methodology is best. And different methodologies are better to answer different questions. So it's not that there's a strict one type is always better. I think many of us, including myself, would want to typically reach for an RCT if we were to say, what is your best form of evidence? But RCTs have limitations. They don't tell us about generalizability. And they are also very hard to perform in certain patient populations that may be hard to recruit in clinical trials. So I see randomized clinical trials, real world evidence, and health economic evidence, particularly healthcare resource utilization like claims, as being very complementary in helping different stakeholders, be they provider organizations, clinical guideline developers, regulators, payers, to answer different questions. I do think what is essential, Steve, is that we do publish that. So I think healthcare is a show me sport, not a tell me sport. And so it's really important that that evidence goes through. There are ways where if we standardize implementation, I think it can help population management, but I think it's absolutely critical if we want to build trust and transparency that evidence is published.
Thank you. Triton, how about you?
Yeah, I think the situation with Doxime in terms of the impact of our products and services on healthcare is a little bit unique, because a lot of the outcomes as they relate to the patient outcomes are really not in our hands. It's in the way that the providers are the ones who are using it. So as big as we are, as many users as we have, I think the best way that we check the temperature of how we're doing is really interviewing our users. These are healthcare providers, and just interviewing hundreds of them every single day of just like, how is it going? How are you using it? What is your workflow? How do we make this better for you? So we do use some internal metrics like the NPS, Net Promoter Score, things like that, usability metrics and stuff. But to us, the biggest thing is honestly at this point, it's stories from our users.
Wonderful. Varun, how about you?
So as I mentioned, we actually have a research division that's almost a decade old, and we've got over 20 peer-reviewed published research papers, and a lot of them have been randomized control trials. So we have a lot of data out there, and most of the studies were designed around showing the efficacy of our treatment modality of asynchronous therapy, chat therapy, telepsychiatry. So all of that is out there. In addition to that, we looking at the clinical outcomes, we try to be as measurement-based, informed care as possible. We do PHQ-9s and G87s on our patients, and we track that. And in addition, we get the clinical subjective information from our providers as well. So for us, it's multifaceted, whether we're looking at research or whether we're looking at the outcomes and the process data that we collect.
Thank you, Varun. Naz, how about you?
Yeah, thanks, Stephen. Also same for us, like we are like, very well, established on research, like I lead a research lab, and we have, published over 15 trials. We have like about 12 trials right now. It is very important that like the work that you do is evidence-based to like build that trust. That what you are doing is based on evidence, to show that to like, the health providers as well. And also, I think the other thing, it is important that you say that you showed this in the research, but also show that people who use this saw it like in industry as well. So, well, like for example, our solution, one of the things is we are saying that we're lowering the cost. So one of our customers is offering a whole round of 12 sessions of psychotherapy at lower than 500, which gets you like 2 sessions, right? So like, I think it's important to show it like with evidence in research, and also show it like as people who use it. And that is like how we are doing it, combination of research and also what you offer. So that I think it is very important.
We actually will go extend just a little bit so that we can answer this important question about access. So this particular attendee asks, how might the makers of PDTs, prescription digital therapeutics, respond to the notion that these tools improve ease and time to access for persons who do have insurance or employee benefits, but do little to serve the needs of those without access, such as minority communities and rural populations?
So yeah, we are not a care providing company, but like we are working on like developing a tool that could be used by like the clinicians and like by the hospitals and the care providers.
Makes sense. Thank you, Naz. Varun, how about you?
So we don't have any prescription digital therapeutics, but we certainly have a number of therapists that are familiar with them. And our therapists, independent of Talkspace, being clinicians, can also let members know about what's going on out there and if this is something that's appropriate for them. So we anticipate in the future there's going to be a lot more interaction with prescription therapeutics for our members.
Thank you. And I recognize that not all companies here are necessarily PDTs, but I just wanted to give the opportunity equally. So thank you. I'll also then pass it on to Triton.
Yeah, similarly, Doxime does not offer PDTs, but I will just speak, I guess, generically about health technologies and how accessibility to these things is limited by known factors like rurality, costs, location, internet activity, and things like that. We think the biggest way to empower people to access healthcare is to empower the providers, because it's the providers who are the gatekeepers. It's the providers who are the ones reaching out to their community members. It's the providers who are on the ground, and they can access the people who need healthcare. So one of the biggest things I'm very proud of here at Doxime, and I've heard this underlying theme across all the speakers, all present company here, is we make costs not an issue for providers. All of our products are free for individual providers, and it's the larger organizations who we charge the fees to subsidize that for everyone. So making it free, and other things we've done lately or recently, we're expanding internationally to do translations of our software and all of our solutions in I think 19 different languages at this point. So yeah, there are known factors, as Murray hinted to, that there's not a lot we can do about, but all the other things is just getting all of that stuff out of the way as much as possible.
Thank you, Triton. And last but not least, Yuri, would you like to share your thoughts?
Sure. So, I mean, I think it's a really important question. And sadly, I think for a long time, a lot of digital health was really focused on people who made $100,000 a year and could pay out of pocket for their own products. So it is really important that we call attention to how can we help all patients get access. I mentioned earlier some of the work that we've done where by really focusing on rigor, that we can start to expand access to Medicaid patients and patients that would otherwise not be able to get care. There are definitely patients who are uninsured. And so one thing we've done, and I know many organizations have done this for a long time, is have patients assistance programs whereby patients can qualify to get access for free. If you have to comply with state pharmacy laws, then there are requirements to do that. You can't just give it away, because that could be seen as an inducement. So you have to follow those PAP requirements. But I also just want to touch on, particularly for minority communities and rural populations, one of the things that we didn't really touch on today is digital equity. And that's something as well. So we've done a lot of work looking at rural access, building tools that support, for example, older handsets, older Android phones, having store forward capabilities so people do not have to have an active internet connection. And we see that as really important because we see a lot of patients that we serve who are using very old Android handsets, and maybe their internet connection is when they go to the clinic or when they go to McDonald's or the local library. So I think that's something we can all pay attention to, is how do we bridge those access points as well.
Thank you for bringing up that term, digital equity. That's absolutely important to make sure that no one's left behind in this digital revolution. Thank you, Yuri. Well, that's the last question we have, and I know that we were over time, but I wanted to thank our panelists for sticking with us and answering our audience questions. We all just heard from Yuri Maricich from Pear, Triton Ong from Doxy.me, Varun Choudhary from Talkspace, Alavi from Health, and Zucker from Twill Health. So we will wrap this up, the session, and I just wanted to thank Tori, Katie, Rachel, Ipsit, Justin, Nicole, Scott Rauch, and more, who have allowed me to be with you today. On behalf of the rest of the steering committee, thank you for joining us for this session.